Today we're going to talk about fever and neutropenia. So our first objective is to recognize fever. So in these patients, fever may be the first sign of a serious life-threatening infection. And what do we consider true fever? So for the cases of fever and neutropenia, we're really talking about a temperature of at least 38.3 Celsius or 101 degrees Fahrenheit. And research has demonstrated that fever occurs in up to 1/3 of neutropenic episodes in patients following chemotherapy or bone marrow transplant. And that really translates to a rate of 0.76 episodes of fever per 30 days of neutropenia. Okay, so now that we talked about the fever piece, let's talk about neutropenia and what that means. So neutropenia is defined from your ANC, or your absolute neutrophil count. And a patient is neutropenic if his or her ANC is less than or equal to 1,500. And there can be some confusion with this because for cases of fever and neutropenia, we're really only talking about an ANC less than 500. And how do we get an ANC? Well, it has to do with, of course, our white blood cell count and our neutrophils, with the equation as follows. So it's going to be your total white count times your percent neutrophils plus your percent bands divided by 100. And as I was saying previously, for cases of fever and neutropenia, we're really talking about an ANC less than or equal to 500 currently, or an ANC that is expected to fall to less than 500 over the next 48 hours. Okay, moving on to our next objective, which is management of patients with neutropenic fever. So we have a patient with a fever greater than or equal to 38.3 degrees Celsius, and we know their ANC is less than or equal to 500. So the first thing we want to do for management is stratify these patients into high risk versus low risk groups. So who is high risk? So these patients have an ANC less than 500, which is anticipated to last at least an additional week or 7 days. These patients might have evidence of hepatic insufficiency, which is defined as an ALT more than 5 times normal, or renal insufficiency. And these patients could have comorbid medical problems, which could include hemodynamic instability, mucositis, so that skin breakdown predisposes you to infection, GI symptoms, neuro or mental status changes, central catheter infection, pulmonary infection, or underlying pulmonary disease. And which patients are low risk? So these patients have an ANC, again, less than 500 because they're neutropenic, but it's expected to rise to above that level within the next 7 days. They have stable and adequate hepatic and renal function, no active comorbidities. And select patients in this group of low-risk individuals may be carefully selected for outpatient treatment, but these patients would need solid social supports, they would have to have daily follow-up, and obviously have to be presenting without signs of sepsis. Great. So now we've stratified our patient as either high risk or low risk. And we're next going to do what we typically do for all of our patients, which is to get a thorough history and physical. And in these patients, it's important to cover some key aspects of the history exam, specifically any new site-specific symptoms, infection exposures, a history of documented infections or colonization, recent surgery, previous chemotherapy agents used, or intravascular catheters or other devices that the patient may have. And for physical exam, it's always important to start with the vital signs. Do you guys remember the first vital sign that we would expect to change to indicate sepsis? Yep, that's right, heart rate. So pay close attention to tachycardia. Do a thorough skin exam, including looking in the folds, the nail beds, or at any central catheter exit sites. Look in the oropharynx with close attention paid to the gingiva, because mucositis can lead to skin breakdown there. do a lung exam, abdomen, and of course look at the perineum. And it's important in these patients to not ignore any mild erythema because they're immunocompromised, and erythema might be the most dramatic reaction the patient could mount to infection. We're next going to discuss any relevant labs that you might order for these patients. So which labs do we get on these patients? Well, any patient presenting with fever and neutropenia is going to get themselves a CBC with diff, a BMP, which of course includes electrolytes, BUN, creatinine, and a serum glucose, liver markers, so that might include AST, ALT, ALK-Phos, and a total bili. And most importantly, of course, are going to be blood cultures. And in these patients, it's important to get a sample from every lumen of a central catheter. Most of the ports that our kits have 2 lumens, so getting a sample from each, as well as a peripheral culture, because that can help us distinguish if it's a catheter-related infection or not, depending on how long a bug will grow on a peripheral versus a central culture. Now, although there are not universal guidelines in terms of what lab work to get for these patients, some research does suggest also getting a CRP or a lactate, as these are markers of infection. And if the patient is under 5 years old, there is a general consensus to do urine testing as well, especially in girls who have a higher risk of developing a UTI. And the remainder of the workup is really going to be dictated by the signs and symptoms of the patient. So you might think about getting a nasal swab if there are URI symptoms, a chest x-ray for the same, or if you're concerned about a lower respiratory infection. It is important to note, though, however, there might be a delay between symptoms and the development of infiltrates on a film. Abdominal imaging if there are any GI complaints, a lumbar puncture if mental status changes, keeping in mind, of course, the patient may need platelet transfusion prior to this, and if there's evidence of diarrhea, possibly sending C. diff testing. Now let's talk about the most common bugs or pathogens that lead to infection in patients with fever and neutropenia. So in terms of specific pathogens, there has been a recent increase in gram-positive bugs over the years due to the use of prophylactic antibiotics and the increase in indwelling venous catheters. And the most common of these bugs are coag-negative staph, viridans strep, and Staph aureus, including MRSA. You also worry about gram-negative bugs. About 1/3 of infections are from gram-negative bacilli, including E. coli, Klebsiella, Pseudomonas, and Enterobacter. And in these infections, you're really concerned about rapid development of sepsis and hypotension. In terms of fungal infections, which are usually candidal, these are less likely the primary pathogen and are more common after prolonged course of antibiotics. And the use of prophylactic antifungals has also led to increasing infections with Aspergillus and Cryptococcus. And then, of course, if a patient's coming in with severe GI symptoms, you would also want to consider anaerobic coverage. Now let's talk antibiotics. So research has shown that the cornerstone of treatment for these patients is empiric antibiotics. And the key is the initiation of antibiotics in no more than 60 minutes following presentation. And starting antibiotics after 60 minutes has been associated with increased risk of adverse outcomes and increased length of hospital stay. And when selecting an antibiotic agent, one must consider risk stratification for the patient, any allergies, presence of organ dysfunction, current chemotherapy regimen, or whether the patient was receiving prophylactic antibiotics, and if they have a history of previous colonization, especially with MRSA. So now let's discuss specific antibiotics. So initial treatment for all of these patients is going to be with a beta-lactam, a cephalosporin, either cefepime or ceftaz, as these provide good gram-negative coverage as well as pseudomono coverage. Both of these medications are dosed 50 milligrams per kilogram IV every 8 hours, up to 2 grams per dose. Next on our list, vancomycin is not routinely used unless history supports its use. So perhaps the patient has a history of MRSA infection, there might be mucositis or skin breakdown that makes you more concerned about gram-positive infection, or perhaps the patient looks clinically ill or sick. It's important to keep in mind development of vanco-resistant enterococcus, however. Flagyl or metronidazole may be added for anaerobic coverage if you are very concerned about GI symptoms and possible GI infection. Meropenem offers the same beta-lactam coverage as cefepime or ceftaz, but may also be added if you're concerned about anaerobic resistance. And finally, amikacin, an aminoglycoside, is often added if there's true concern about a gram-negative infection, and providers feel the need for double negative coverage. As discussed earlier, fungal coverage is not routinely added right from the get-go, but may be considered if the patient had prolonged or very severe neutropenia or has a recurrence of fevers. Now let's briefly discuss interpretation of lab results as well as management of these patients. So now let's take a look at some of those labs that we were talking about earlier. So all patients admitted for fever and neutropenia will receive a daily CBC to monitor for signs of count recovery, which of course include ANC, but it's also important to look at the number of monocytes, which can be another reflector of count recovery. Also pay close attention to a patient's BMP to monitor for signs of metabolic acidosis, which can of course indicate severe infection or sepsis. And then the most important lab to monitor is of course the admission blood cultures. And the traditional strategy with these patients is to follow the admission culture, both the peripheral and central ones, for signs of growth. And typically, if a patient has no bacterial growth of a culture for at least 48 hours, has been afebrile for 24 hours, and has shown some sign of count recovery, the patient is typically deemed fine for hospital discharge. And as mentioned, although most institutions do not require an ANC greater than 500 for hospital discharge, they do require some sign of count recovery, whether that's a rising ANC, perhaps more monocytes, or both of the above. It's also very important to provide patient education for these patients and families upon hospital discharge, reflecting that fever might be the only sign of serious infection in those kiddos. So it's very important for family to closely monitor for fever or other signs of clinical distress at home. These patients will also have to have very close clinic follow-up and typically will be seen within 1 to 2 days of hospital discharge. And a few other points to mention about treatment. Of course, if a patient demonstrates a positive blood culture, that will dictate treatment and usually warrants at least a 7-day course of IV antibiotics. In these kiddos, we're obviously very slow to label anything as a contaminant, and it's important to have a discussion with the infectious disease doctors as well as the heme-onc attending to discuss if something could be a contaminant on culture. Certain bugs that do grow on the culture will automatically lead to discontinuation of a central line, including yeast, but those are more extensive conversations to have with the rest of the team. Great work! You've made it through all the important points about fever and neutropenia. Now it's time to practice IPASS format. As you've been learning, IPASS consists of a summary statement about a patient reflecting their clinical status, and problems are based by system. So let's practice. This is Mona Sight. Mona Sight is a 5-year-old female with pre-B ALL, currently in maintenance phase of chemotherapy, who is stable on the Hem-Onc service after being admitted for fever and neutropenia 1 day ago. Here are her problems by system. 1. Fever. Her last fever was on 11/27 at 4 a.m. Her admission blood cultures ×2 from her port and 1 from the peripheral site have shown no growth to date. She is on IV ceftaz, which was started on admission. From an onc perspective, she had an ANC of 50 on admission. Her hemoglobin was 7.5 with platelets of 20. We're holding her daily 6 MP due to her counts. For FENGI, she's tolerating a regular diet. She's on maintenance fluids with D5 Normazole, and her admission BMP was within normal limits. For contingencies for Mona overnight, if she has a temperature greater than 38 degrees Celsius, obtain repeat cultures, both central and peripheral. If she's looking clinically worse, add vancomycin coverage. Call the Hem-Onc team with any fever or clinical change. And there you have it, a review of fever and neutropenia. Good work!